This is Selma Schimmel in Chicago at the annual ASCO meeting for the group room, and we're going to shift our discussion now to gynecologic cancers as we welcome Dr. Professor Lynette Denny, head of the Department of Obstetrics and Gynecology at the University of Cape Town, and Dr. Denny is also president-elect of the International Gynecologic Cancer Society. Welcome to the group room.
Thank you.
Let's talk a little bit about what was presented here at ASCO that you have found most compelling in the area of gynecologic cancers.
From my own perspective, from Africa, very little. There is, it's like Africa doesn't exist. So the focus is very much on high-income countries. But for me, working in that environment, it's very exciting to see what's waiting for us in the future. And all the work gets done here, and the evidence will be gathered. And hopefully by the time that it can come into the African context, it'll be affordable. So it's very important for us to know where the excellence is and to understand excellence. And the science that is practiced in the northern parts of the world can in fact also be done in the southern parts of the world. And many of these innovations can be translated to help our patients as well. And remember, the demographics of all the poor parts of the world are changing. And as they industrialize, they start to develop the same diseases as people do of lifestyle in the northern part of the world. So for me, what's been compelling is to look at the science, is to look at the innovation in the science, and how much support there is for it. You know, we have the saying in Africa that, you know, research and health is a key driver for the development of your country. And a key, you know, for your governments to invest in the health of the people is a huge drive to improving the quality of life of all your people. And cancer is becoming a big disease in Africa. It's increasingly big, and it's not recognized. Everybody thinks of malaria, tuberculosis, and HIV, but in fact, there are about 700,000 known individuals suffering from cancer in Africa, and 80% of them diagnosed with cancer will die from their cancer because they present late or lack of access to treatment. So from my point of view, it's very important to see what is out there, what's possible, and find ways of bringing those innovations for the benefit of the African people.
Is the BRCA mutation as frequent in where you come from, South Africa?
Well, one of the problems is that we don't test all that much for it because it's expensive, and our world is sort of dominated by cancer of the cervix. So, however, breast cancer is now becoming one of the commonest cancers amongst women in Africa, even commoner than cervix cancer in many countries. So that in itself is interesting, because the question is why. And Dr. Olopadi's group have identified the triple-negative breast cancer patients who have disease at a younger age and more aggressive and are not BRCA1 or 2 positive. But we certainly have BRCA1 and 2 positive families, and we practice similar interventions as you would find in the USA, but it's not kind of routinely done. For example, genotyping for cancer is not routinely done because the resources to do that are limited. So we have a very large burden of disease in African countries, including South Africa, with much more limited resources than you have in the northern parts of the world. So we have to triage. So, you know, a woman with ovarian cancer will be treated in a similar way as she would be in the States. She would have maximum surgery, you know, full debulking. We use single-agent chemotherapy in our first line, and we have to get very special permission to use the paclitaxels.
What would be your single agent?
We use carboplatin. And if you look at the data, the long-term data, it doesn't actually affect overall survival whether you use 1 or 2. Although it's standard of care in the US, when you really look at the ICON studies, whether you use carbo alone or carbo with paclitaxel, your 5-year survival rates are very similar. So where your health dollar is critically limited, you are much more evidence-based. So we study the evidence very, very thoroughly to make sure that our interventions are cost-effective and in the best interests of our patients.
I want to thank you for bringing a worldview, sharing a bit about what it's like in other parts of the world and in a country in Africa, in particular South Africa, and what your own impressions are as you go back and you work internationally, but it must be in some way frustrating to be in a wealthy country and look at our access and possibilities and choices, and then go back and see so many women who are in need that don't actually have as much of a selection of treatment options.
Yes, it is, but we live in hope.
Thank you.
Thank you very much.
Dr. Lynette Denny, Head of the Department of Obstetrics and Gynecology at the University of Cape Town in South Africa, President-elect of the International Gynecologic Cancer Society.
Thank you.